So very warm welcome, Dr. Aroca. It's a very big pleasure to have you here today and to share the next 60 minutes plus with you. What I propose is to do a short introduction to the audience. But before that, what we will do tonight is around 40-45 minutes presentation. Then there will be a Q&A. During the entire session, please write your questions in the Q&A app at the bottom of your screen if you have a PC, or at the top if it's an Apple. We will take them then one by one at the end. So that's a bit about the technicalities. This session is recorded. The content will be used at a later stage, and it's also in live streaming on Facebook tonight. So, Dr. Aroca, a short brief about yourself. So, you graduated from the Dental Surgical Medicine University of Budapest in Hungary. You have been assistant professor at the University Paris 7 in France from 1998 to 2001. You did a postgrad in biomaterials at the same university. And in 92, you got certified by the University of Paris 7 in periodontology, followed in 96 with a postgrad in periodontology and oral implantology. You are a visiting professor on postgraduate in periodontology and oral implantology at the University Paris 7 since 2001. You hold a PhD from the University of Szeged, if I pronounce it correctly, in Hungary. And you're also an honorary professor since 2012 at the same university. And since 2009, you're also a visiting professor at the University of Bern, where we met you, in the Department of Periodontology with a very dear colleague, Anton Skulian, as well. So on these words, the stage is yours. I'm gonna let you share your screen and let you take the time to enjoy this presentation.
Okay, let's go up now. Okay, and just let me go to the presentation. Okay, thank you. Really, thank you very much, Alexandre, for your kind idea to give me the privilege to share with you all, even if I cannot see you, and for me is a big pity that I cannot see you, but I am extremely happy to share with you my clinical experience in treating soft tissue and periodontal defects. And for me, the soft tissue are also periodontal defect, and in this case with hyaluronic acid. I go for we will discuss mainly three topics. We will share a little bit of what we know so far about the hyaluronic acid, and therefore the biological and clinical benefit to use hyaluronic acid in our clinical practice. Also, of course, we will talk very much about clinics, and I will share with you which kind of defects we can treat and how do we treat them. I told you that it will be extremely clinical presentation because I am first of all a clinician. Let's go deeply into the topic. I think that the periodontal tissue regeneration is one of the most attractive and biological elegant way to lessen the risk of the periodontal disease recurrence. What I mean, for sure that the main therapy is, of course, the inflammation, the infection control, inflammation control. But the periodontal disease leave some sequelae. And in order to really frankly lessen the recurrence, we have to go further in the treatment, of course, always under infection control. And what you can see here, that all of these device or bioactive agents that we use, all of them show certain degree of healing with a very promising histological result. But in this case, we will discuss a little bit more about the hyaluronic acid. What we know so far, that the hyaluronic acid is a key element, is part of our human body, of course, is the major component of the extracellular matrix. But we know that, of course. Let's go a little bit more further from a clinical standpoint. I will share with you not too much, but 3 studies that caught my attention so far. The first one was performed by the Bernice group, and they performed a systematic review and meta-analysis with 11 RCTs, and they observed that the adjunction of hyaluronic acid improve the clinical outcomes when they use with non-surgical and also with surgical periodontal therapy. Therefore, from a clinical standpoint, it will be really interesting to go further with that. But let me share what is, I like very much this study, because it's the first study, experimental study, by the way. The previous one was a clinical study. This is the experimental study that for the first time they provided histological evidence for periodontal regeneration of gingival recession defect following coronally advanced flap. Here you can see on the left side, you can see a very, very, very nice pictures and illustration of the regeneration when the hyaluronic acid was, the coronally advanced flap was used with hyaluronic acid. And you can see here on your right side, only the coronally advanced flap without hyaluronic acid. Therefore, for me, from a clinical standpoint, even if it's an experimental study showing for the first time, but is caught, of course, my attention. And the third study is a very interesting study because it's a randomized clinical control study, as you can see, with 2 years follow-up, done by the Italian group, the team of Professor Andrea Piloni. They observe, they evaluate the hyaluronic acid in Infrabony for the treatment of Infrabony lesion. Of course, they evaluated the hyaluronic acid with the enamel matrix derivative, and of course they also observe favorable outcomes in the treatment of Infrabony lesion when they use hyaluronic acid. But also I have to mention that the clinical result, they had better result with the enamel matrix derivative. We have to underline, we do not have time in order to go further, but only thing that I want to share with you, that when you do this kind of clinical studies, when you want to compare two different bioactive agents combined with surgical, for recession coverage, or in this case with intraponylation, you should also maybe add a third group of patients in order to really better evaluate the influence of the bioactive agent. But it is extremely interesting. But I really advise you to go to read this, not only these 3 articles, but even more. Reading a lot of articles, not only 3, from a clinical standpoint, what are the positive outcomes of the hyaluronic acid? You can have a lot of evidence of the antibacterial effect, also anti-inflammatory effect. For us, for in periodontal lesion, periodontal lesion treatment, periodontal defect treatment, for us is extremely important from a clinical standpoint. And also what I like very, very much, that a lot of studies mention that the use of hyaluronic acid helps in the stabilization of the blood clots. And of course, there are so many biological properties that they favor the wound healing and also enhance the expression of genes encoding for the type 3 collagen. Therefore, you know, all of those biological properties for me, for a clinician that I am, are extremely attractive. Once again, even if we discuss about hyaluronic acid, there is, all of you know that there is not the only one, of course, bioactive agent. What kind of defect do we treat? Do we treat, of course, recessions, furcation lesions, and Infrabony defects? Therefore, these 3 types of periodontal lesion and soft tissue lesions as well, because for me, the recession is not only soft tissue defect. But before we go further, I do want you to keep in mind the following statement, that the name of the game is the management of the soft tissue. Therefore, of course, it is extremely important in order to have the knowledge how to use a bioactive agent. But of course, the name of the game is the management of the soft tissue when you treat all different, all the type of the periodontal lesion. And you will understand at the end of my presentation, I hope so, that why I ask you to keep in mind these statements. First, the first defect that we will see so far is the recession coverage. Here you can see that we have 3 types of recession defects. The parameters that you have to take into consideration when you plan a surgical intervention is not only the depth of the recession, as you can see, but also the gingival thickness, the width of the chitinized tissue, the parameters that belongs to the soft tissue itself, but also you have to take into consideration the defect on the hard tissue, means that the presence or the absence of the cement-enamel junction, or there is if you deal with an abrasion lesion or a non-carious or carious-surgical lesion. Of course, you have to, these parameters must be clear in your mind in order to plan. Once again, you know why I am always going back a little bit, because keep in mind that the successful treatment will be due not only to the materials that you use, but how you will manage your surgical intervention. And for that, the parameters, the clinical parameters must be extremely clear in your mind. The complete root coverage, of course, is the ultimate clinical outcomes. At the end of the surgery, we have to, at the end of the surgery, the stability through the course of time, we have to have a minimal pocket depth, and from an aesthetic standpoint, the soft tissue blending must be favorable, of course. And the goal as well is that we, with our surgeries, we modify all of those clinical situations which impair the plaque control, mainly when we deal with the lower arch. Going a little bit deeper in what I would like to transmit today with this presentation, I did not talk about the indication of recession coverage, but the goal of our surgeries is to achieve a complete root coverage. And you know, the indication of root coverage, the most of the time we are talking about aesthetics, and it is the first indication that we always use. I do not agree with that, even if we have, of course, that indication is valuable, but I do not agree with that, because you have to understand that we lost periodontal attachment, we lost tissue, we lost not only soft tissue, but with periodontal tissue, which means we lost also bone, a part of bone, ligaments. Therefore, we have to keep in mind that when we go for recession coverage, we have to think regeneration, rebuild the loss of the superficial periodontium. And in order to illustrate better what I do want to share with you today, let me show you this patient with as you can see, multiple recession in the maxilla and the lower arch as well. And this patient was complaining with a huge pain on the upper left first premolar. And his dentist was asking him if there is no problem, you brush too much your teeth, there is no problem. If you do not have aesthetic demands, aesthetic problems, leave it that. But this patient came to the university, and you will see that he has not only multiple recession, but also cervical lesion, non-cariocervical lesion. And what you can, maybe you cannot really see from the slides, that we have kept nice tissue at the apical aspect of each recession, except on the first maxillary premolar. And the patient was complaining not only of hypersensibility, but a little bit much more pain. And what you can see, that if you take a perio probe and you do as you have to do the examination around all the recession and the mouth, you can see here that we have a huge pocket on the buccal aspect of this premolar. And you think that the patient, of course, that the patient was complaining, but he didn't know that he had this pocket. Therefore, and also suppuration and bleeding on probing. We started to treat because, as I showed you before, that according to the parameters that we took into consideration at the beginning, we knew that we have to rebuild the cervical lesion before the surgery. And we did on the upper left quadrant. You can see here that it was rebuilt with composite, all the concerned teeth, and you have a closer view here. And now in this case, because we have to elevate, you know that we have several surgical techniques to go for recession coverage. But in this way, in order to go deeper into the lesion, of course, we have to choose not the tunnel technique, but the multiple coronary advanced flap technique that was described by Giovanni Succhelli and Professor De Santis. Here you can see, but we do not describe the surgical steps of this technique because maybe you know very well what I want to show you. That here you can see that a huge calculus, and since this around the tooth, the chitinized tissue was not enough, of course, almost the mucosa detach very easily from the root surface. You clean very well without raising the flap. You cannot see. You cannot know really well to perform the root planning as you must be. And here you can see that we use ultrasonic devices as well in order to clean well this root surface. Afterwards, we remove in order to advance coronally the flap, you know that you have to remove the epithelium from the anatomical papilla, and we apply a connective tissue graft over the cuspid, the first premolar and the second premolar, because it was in the three sides, the keratinized tissue width was not enough. And you can see that the connective tissue graft is fixed to the base of the anatomical papilla, because we left connective tissue there, and we cover completely. And at this time, at this time, you can apply your bioactive agent, of course, at this time, because you can apply over the root surface and over the connective tissue graft. You cover completely, and you fix with separate suture, as usually we do. And please have a look on the secretization over the course of time. Here the patient before and the patient after more than 1 year. And please observe the stability of the gingival margin. Another case that I want to share with you, maybe some of you know, it was not easy to choose the surgical technique because you have 3 recession, small recession, and a huge recession here. There was not, you can see also, maybe not very well, but you can see that we have keratinized tissue with, but very, very, very little, at least 1.5 millimeters of keratinized tissue width in the apical aspect of this deep recession from the maxillary cuspid. And the same surgical technique that you saw before, but less extended. You can see here that we already remove the epithelium from the anatomical papilla, and the bioactive material was applied. Here you can see that we apply to the root surface. And what I like in the use of the hyaluronic acid, if I do want to be a little bit more practical, is that you can use, you are not really, it's not mandatory to have not to have blood on the root surface. You can use, and if you have a little bleeding, does not matter, because the efficacy does not impair the efficacy of the hyaluronic acid. Therefore, it's very, very easy. From a clinical standpoint, it's extremely easy to use. And also, I always add the hyaluronic acid to the connective tissue graft, as you can see here. And we place the connective tissue graft. We fixed in the same manner that you could see before. In this case, the connective tissue graft is a little bit more thicker. Why? Because you saw that the recession is extremely deep and wide. Therefore, in order to support better the flap, I use a little bit thicker connective tissue. We cover completely. We fixed with separate suture, and you can see here the cicatrization, a very close view of the cicatrization at 1.5 years. I have also, maybe you can see later on in publication, a 3 years result of this case. Here, before and after. Another case that I treated with hyaluronic acid, it was this lower recession. Extremely difficult case. This patient came to me before orthodontic treatment. You can see that she has a thin phenotype, a lot of plaque. Therefore, do you remember that one of the main goal of our treatment is to facilitate, to make easier to the patient to also to have all plaque control. And in this case, we have to go for recession coverage. We have to rebuild as much as we can the periodontal here in order she can undergo for an orthodontic treatment. And we first, of course, we treat because this patient had also periodontal disease. Therefore, we control the inflammation, the infection, and you see, please have a look at the reevaluation phase. She really was, she is still, of course, a patient who cooperates very, very nicely. Very nicely. We start from this situation. Please just have a look. Do not focus on the bioactive agents, or do not focus on the defect itself, but please focus in the way that we solve from a surgical standpoint, and the use, of course, of the bioactive agent. There are several things. There is not only one. There is no miracle. Please have a look after how the capacity of the soft tissue to heal around this huge recession. Have a look only from the first time to the second phase at the reevaluation. And this patient, of course, with this kind of defect, she has, for her, it's not easy to brush. And here you can see that we applied the hyaluronic acid to the root surface, because I wanted to give all the possibilities to heal in the better manner. That's why maybe one of the questions, why do you use, in this case, bioactive agent? Because I really wanted to give all the chances that this tooth heal. rotation, open bite, lingual pulsion. There were too many risks. Therefore, I did not want to lose any occasion in order to favor the cicatrization. Connective tissue graft, the fixation of the connective tissue graft. The flap, the connective tissue graft was completely covered by the flap and fixed, and you can see the result at the end. 1 year. I asked the patient to wait 1 year before she go for the orthodontic treatment, and now she's under orthodontic treatment, and we follow her every 3 months. But please have a look that we really could resolve. Maybe we have a little bit of recession, but all of you, and there is also an extrusion. Therefore, these kind of cases are extremely difficult. In order just to illustrate that, I show you different clinical surgical techniques, and I did this case with the tunnel technique, recession coverage, cervical lesion, non-cariocervical lesion. Of course, as you could see before, we rebuild the cervical lesion, and afterwards we go for the surgical treatment. And what is extremely interesting here, that you can see that we have wide recession on the upper molar, but we have enough keratinized tissue. You can see from this what I am showing you from this picture, that we have enough keratinized tissue. I could move very nicely. We have enough keratinized tissue here in the neighboring teeth as well. Therefore, I decided not to place a connective tissue graft, only hyaluronic acid under the tunnel. Of course, I applied hyaluronic acid to the 3 treated teeth, but the only connective tissue graft around the cuspid, where the width of the keratinized tissue was less than the neighboring teeth. And please have a look. Of course, you have on your left side the tunnel completely advanced in a coronary position, fixed with suture around the contact point. And on your right side, you can see the cicatrization at 2 years now. Yes, 2 years. And you see the stability of the gingival margin around the molar, where I did not place a connective tissue graft. Here, I treated a furcation lesion with a connective tissue graft on the lower molar. This patient came to me not because she was bothered by the recession, but she was bothered by the huge hypersensibility, and also around the cuspid and the molar. I decided to go for the same. You can see that we have class 1 furcation lesion on the lower molar, and the recession you could see before. I elevate the flap in the same manner that you saw in the previous cases, with the epithelium removal in the anatomical papilla is always the same. I apply. You can see here that we have blood, but it does not matter. You apply your hyaluronic acid, your bioactive agent, and very quickly you place over the connective tissue graft, which also over the connective tissue. When you harvest from the palate, as I mentioned and as I showed before, I always I applied hyaluronic acid. The connective tissue graft is completely covered. The fixation with separate suture and also with suspended suture. And please observe the cicatrization through the course of time. All of these cases are, there are not less than 2 years. Therefore, really you can reach a very nice stability of your treatment. Now, okay, you could see that we can not only treat recessions, furcation lesions, but let's talk a little bit about the treatment of infrabony lesion. Exactly in the same way that you have to evaluate the clinical parameters, you have to know so many things about the infrabony lesion, but also how to, which are the parameters that they count, that you have to take into consideration when you go for a surgery. Just let me remind you that we have several types of infrabony lesion, and it is extremely important to know and to have in your mind because it will have an influence in the way that you treat and how do you treat these different lesions. You have a circumferential infrabony lesion, you have 1 wall lesion, 2 wall, and 3 wall lesion, and sometimes you have a combination of those, of course, but it is important because the stability, you have less stability when you have a circumferential lesion than when you deal with a 3 walls infrabony lesion. The increase in stability of what? Of the blood clots. Therefore, do you remember that at the beginning I mentioned that it is extremely important to know which are those bioactive material or biomaterial that can favor the blood clot stabilization. And that's why you have to know how to deal with these different type of infrabony lesion. Here you can see the parameters that you every time you have to take into consideration, as well as for the recession. You have to take the probe and to measure the pocket depth, also the recession, because you know that the recession, the apical shift of the gingival margin is also means that you have a periodontal defect that you have to treat and take that in consideration to plan your surgical management of the defect. And these two, of course, they give you the clinical attachment loss. What we have to know also is to evaluate the morphology of the defect, but already from the radiograph, we can evaluate the defect angle. You know also that the capacity of the wound healing of an infrabony lesion depends also in the angle, the widest angle have less capacity of the wound healing, and you have to go for this really observation, evaluation, all these different parameters, not only parameters, but the morphology of the infrabony lesion will give you a lot of information. And nevertheless, you take into consideration not only the infrabony lesion, the infrabony component, the supracrestal bony component as well, but the quantity of soft tissue. This soft tissue that it is under the infrabony lesion that you will treat, under the infrabony lesions that you will treat, is extremely important. You have to really pay attention to that. Please have a look that to the soft tissue, how you can elevate, which is the difference. Can you see here? I don't know if you can see that the supracrestal, if you elevate the flap, leaving the soft tissue there, you have to respect the healthy connective tissue. You have to respect the only tissue that you have to clean and you have to remove is the granulation tissue, in order, of course, to have access to the infrabony lesion, and take also into consideration the level of the bone crest on the neighboring tooth, leaving the papilla there in order to have a support. But just really think to that. Here you can see, in order to illustrate better my proposal, please have a look in the way that usually we go for a flap elevation when we have to deal with infrabony, supracrestal or infrabony lesion. Here we pay very much attention to keep the papilla. We all go for an intracircular incision. We elevate the papilla, but we elevate the papilla without paying attention to the supracrestal connective tissue component, because you can see that we did not elevate, we left there. But if you leave the tissue to heal, you can, of course, you can close by primary closure. You can see here, but what it is the problem at the end? You have a cicatrization with a collapse of the interproximal soft tissue, because there is no support, because you in this kind of approach, you remove the most important part of the tissue. We have several ways to treat the infrabony lesion, several ways to treat. You have the modified papilla preservation technique, the simplified papilla preservation technique. You have the minimally invasive papilla preservation technique. You have all of those, but you have to, what you have to keep in mind, that every time, if you do not respect the healthy soft tissue in the interproximal area, you will end by having this collapse of the interproximal tissue. And why it is important to take into consideration that, because the risk is that you have a bacterial leakage. And once again, the name of the game is the management of the soft tissue in order to ensure the wound stability. And if you can favor the wound stability, applying a easily applicable bioactive material, of course, agent, of course, you go for that. But the most important is how you manage. Let me share with you one clinical case in details in order to show that why it is extremely important to evaluate from a clinical standpoint all the data. Yes, all the data of here we have in the distal aspect of the maxillary the maxillary lateral incisor, we have deep pocket, but also you can see that this lateral tooth is rotated. We have also a recession. How you can deal with this? With, of course, maybe all of you can tell, in order not to make any aggravation of the recession, we go for papilla preservation technique, because we have enough space in order to elevate and to have access to the infrabony lesion. You can see here that I did not choose that that technique, but an extended in the applying the same principle that the flap to cover multiple recession that it was described by Zucchelli and De Sanctis. Here, the only thing that changed in this kind of cases, that's in the way that you place the oblique incision. The oblique incision, but you preserve, of course, here you are preserving the papilla, therefore papilla preservation technique, and the incision, the oblique incision is parallel to the bone crest, following the direction of the infrabony lesion. You have here as well, you have in the mesial aspect of the lateral an oblique incision in order to advance completely. Therefore, the goal is not only to treat the infrabony lesion, but also to cover this recession. In order that we can advance the flap, we go for a submarginal incision here, maybe you, and the vertical releasing incision, of course, in order to move, because you have to move not only coronal, but to the mesially also this flap, to rotate a little bit this flap. And you see here that we create a recession. But what is important, you can see here the infrabony lesion, and also you could see that what I told you before, that the incision is parallel to the bone crest. Therefore, from the lateral to the cuspid, from the lateral to the cuspid. Please have a look how we elevate, therefore, full split elevation, respecting the description of the previously mentioned flap design. And we elevate the flap, leaving the connective tissue there. We remove only the epithelium. You can see as it was a connective tissue graft already there. Afterwards, we clean, we cut. Please have a look that only the granulation at the base of the granulation tissue was cut in order to have access and the respect of the healthy soft tissue, and this papilla was of course elevated, and you can see that we have an infrabony component of the 3 millimeters, and the infrabony lesion is about 5 millimeters. Please just continue to have a look. We remove the epithelium from the anatomical papilla in the mesial aspect. We harvest a connective tissue graft from the palate and we place there. And at this time, you apply the under the connective tissue graft, you apply your active agent. You place, you fix. Please observe that the epithelium was removed from the mesial aspect of the lateral incisor, also from the distal aspect of the cuspid, but the papilla under the infrabony lesion the epithelium was left there because this papilla is moved in a coronally position, and the connective tissue graft is fixed to the connective tissue that it was left there. Okay, therefore, and afterwards the flap was completely advanced, covering completely the connective tissue graft. And at this time also, I usually place the hyaluronic acid that left over the flap in order to favor the cicatrization. You can see at the 15 days after the surgery, 1 month cicatrization, 3 months cicatrization. You can see, of course, the papilla that it was left there, but please that we go further. And 2 years cicatrization. Please have a look how the tissue healed. And we do not have, do you remember that we had more than 6 millimeters of periodontal pocket? We are now at 3 at 2 years after treatment. And therefore, before and after surgery, 2 years after surgery. Now you can see that we had from radiological standpoint, we have, of course, we have a very nice bone image there. Maybe we can tell maybe we have also a regeneration, but we have certainly a stability of the wound, which allow us to have this result to maintain this result through the course of time. Let me share with you the advantage of the coronal advancement and extended flap, that we increase the space for regeneration. You can see here, maybe you can see that we have the infrabony, the level of the infrabony lesion is there. The cement-enamel junction is here, advancing the flap towards this level. You have an entire space, and moreover, if you ensure stability, you can be sure that you will obtain, of course, the result that you wanted to have. And of course, you start from this, and you can close very nicely. Please have a look that advancing coronally, we can start think that we did successful treatment. Also, another advantage is to reduce the supracrestal soft tissue collapse. I show you the interproximal that we have very frequently, the collapse of the interproximal soft tissue. Advancing in this manner, preserving the healthy connective tissue graft, preserving the papilla, of course, you reduce this collapse. Have a look. You can also, the suturing technique is extremely important, but we do not have time to go really deeply in the suturing technique. But also with the suturing technique, you have to avoid the collapse of the interproximal soft tissue. Have a look that we have a very nice adaptation of the flap, advancement of the flap, and mainly we are able to keep in the same level over the wound healing phase and even after. You reduce the tension also during this coronal advancement, because we are with the full split. Therefore, you reduce the tension at the time of the suturing of the supracrestal soft tissue, and you can adapt. You can see here that you adapt extremely well without any tension. You reduce also the soft tissue compression because you make room to use bone filler, for instance, combined with hyaluronic acid, you know, and you can see that also, and without any compression, any tension, and the most elegant advantage is that you minimize the gingival recession, preserving and improving aesthetic. You saw also before with the clinical case that I just previously shown. You can see the baseline and 1 year after. Therefore, of course, for me, the coronal advancement, the extended flap, the coronal advancement of the flap is one of the most elegant technique in order to treat infrabony lesion. Even if you treat one infrabony lesion, do not be afraid to extend a little bit and to go for the split flap design. Therefore, you can read all of these advantage that I mentioned before: increase space for regeneration, reduce supracrustal soft tissue collapse, reduce tension at the time of suturing, reduce soft tissue compression, and no more gingival recession, or almost no more gingival recession. And what are my conclusion? That the bioactive materials have shown really their biological efficacy because they have a real biological influence and beneficial effect. But our task is to build from and I mean surgically, a favorable environment for the wound healing process can take place, is extremely important, and the surgical management of the soft tissue is the key. And do you remember it was the name of a successful treatment? Therefore, to build, to know how to use, to know very well which kind of lesion you treat, and in order to build. And for me, is if there is one message, please pay attention to the management of the soft tissue. And I hope that you enjoy, because I always enjoy a lot, and I enjoy. And you have some questions or several questions.
Thank you, Sofia, for this very nice presentation. I think the audience also appreciated very much the clinical and scientific perspective that you're sharing here. Yes, for the question, please enter them in the chat or in the Q&A function at the bottom of your screen if you have a PC, or on the top if you have a Mac.
Me, I have a Mac.
You have a Mac, good.
Yeah, I can see.
So we have a first question. What is your experience with papillary reconstruction and black triangle closure with using HA?
What is, I cannot, I do not understand the question, excuse me.
So the question is whether you have experience with regards to papillary reconstruction and black triangle closure using hyaluronic acid.
Yeah. I think the black, the black hole closure. Yeah, I think the hyaluronic acid. Once again, I share with you my knowledge, my feeling, my clinical experience, and I use the hyaluronic acid, combining combining with the surgical technique, several surgical technique. I do not. I think they use only the hyaluronic acid to regenerate, because to rebuild a papilla is not enough. Is not enough. You have to combine. I have several cases. By the way, I always tell Alexander that I will show him, and I never have the time to show him. I have several cases, and with my orthodontist friend, we are. She reduced the space a little bit, of course, with an orthodontic device, and in order not to go for a complex surgical intervention, we inject hyaluronic acid. But for the moment, we are also an experimental phase of that. Just therefore, in order to answer very short to the question, my experience is very little.
Thank you. So next question from Maite. Is there any evidence of the use of injectable HA in minor papillary reconstruction in order to fill interproximal spaces in aesthetic zone?
But what I answered it before, and I think it is extremely interesting to go on that direction. But once again, you have to combine with another surgical or another treatment. In this case, we are with my friend. We are doing with an orthodontic treatment and to rebuild the papilla. But yeah.
Thank you. Question from Adriana. Do you have data on the effect of HA in non-surgical periodontal therapy?
Yes, we have a lot of RCTs, and you have also the first study that I mentioned before, done by the Bernis group. The Bernis group published in 2019.
We will look to Regedent as paid to get this data actually public. We will look to share the link with the public here so that you can access this work.
Yeah, I think it is extremely interesting. Once again, for me, what is the most interesting thing with the hyaluronic acid is that has an antibacterial effect and an anti-inflammatory effect. And when I use, I usually place that over the flap when I finish my surgery, over the flap, and also if I harvest from the palate, I also apply to the wound of the palate. And my patient are there is no problem, there is no pain afterwards. And what I like very much is to observe from a clinical standpoint all the flap when I used hyaluronic acid are extremely clean when the patient comes 15 days after. But always take if you use also when you finish the surgery. Then don't throw away that is left, but use entirely. Yeah.
Good. Here, one more question from Mariola. Actually, it's several questions. So, does it influence to use HA in the augmentation of biologic width with or without bone augmentation procedure?
No, I think the EG, the bioactive agent, is not a miracle. It's not a miracle. You have to, as a clinician, you have to know how to build a favorable environment in order the bioactive agent can express its biological property. You have to know, you have to build. It is really my clinical experience, my knowledge is it is attractive is the biological properties. The biological properties, the first, repeating myself, the antibacterial effect, the anti-inflammatory effect, and the capacity to stabilize the blood clot, the capacity. But go back a little bit to the clinical illustration for the infrabony lesion that I showed you. If you do not pay attention to all the steps surgically, if you have a collapse because you did not pay attention to keep the soft tissue there, if you have a collapse, it's not the hyaluronic acid that they will give you. You did not give the possibility to that hyaluronic acid to express his biological capacity to regenerate. You understand what I mean? That is you with your hands and with your clinical knowledge that you will allow to the bioactive agent to act. Is not the contrary. You cannot place like that. For instance, nobody could think, or nobody can think that you go for a surgery with an inflamed tissue with plenty of plaque. Why not? Because we know that we do not have any chance to have a wound healing or to have a successful treatment. We have to go first for the inflammation control, infection control. Therefore, what does mean? That you are building a biological favorable environment for the tissue heals, and you do exactly the same when you are using a bioactive agent. You have to build in order that express the efficacy. Otherwise, that does not work. You have to prepare the place, the room, the environment. I wanted to tell the terrain, but I don't know, that has not come to my mind. Yeah. Yeah, but you have to really, it's you have to build. Yeah, bioagent express biological properties, but you allow that with your hands.
A bit related to this topic, so is there any rationale to add HA to other regenerative materials as bone substitute?
Yeah. By the way, I in the same way that we use the enamel matrix derivative with, for instance, in this case with the biomaterial, I do exactly the same with the hyaluronic acid. And is extremely easy. It's extremely easy to do. I have several cases with that. I also use hyaluronic acid for the treatment of some peri-implant lesions, because I'm repeating a lot of myself that for its antibacterial effect.
Many questions. I tried to group them a little bit. You mentioned Emdogain, so he's HA versus Emdogain. What do you prefer, and when do you use each one of them? From Hussam.
Since I think the indication to use the enamel matrix derivative or the hyaluronic acid are more or less the same. really the indication, because now even if the hyaluronic acid is a little bit new in our clinical practice, but because it's not new really, but in our clinical periodontal clinical practice is a little bit more recent. The indication are the same, and now we have a lot of studies showing that for regeneration, that there is histologic evidence now for regeneration, and we start to have a lot of result. Therefore, for me, the indication is the same. What I mentioned before in the presentation, that from a clinical standpoint is very easy to use, and very easy in a way that if the site is bleeding a little bit, you know, you place the bioactive agent at the end of your surgery, and the patient, if the patient is tired of, there is always a little bit some bleeding at the end, you can use very easily. You don't need to have a dry root surface in order to use it. Therefore, for me, is very, very easy. The indications are the same.
Okay, thank you. So then more questions related to the hyaluronic acid you're using. First one from Avigdor. Have you tried different HA viscosities for various indications?
No. Frankly, no. I use only that for the cross-linked hyaluronic acid. I use only that for periodontal reason. I do not use for aesthetic for the lips or for the face. No, I do not use that. I use only one.
Thank you. Similar question. Would you know if HA for fillers can be used in periosurgery?
No, I don't know, but the question is for Alexander. It's not for me. I do not know. I do not have, and I really don't know, and I think it's not.
I mean, I'm obviously an industrial, so I'm biased, but
what will be the advantage of that? What will be the advantage of that?
I think already from a regulatory perspective, this would not be allowed because these type of products are not in the same classification.
Yeah, but what would be the advantage to use that? Of course, is another, I think is another topic, but yeah.
Sorry, I'm just going through all these questions. Would you combine Emdogain with HA?
No, I think is why no, I know for them to do what no, why, which is the once again, which is the interest to combine these two bioactive with a bone filler? Yes, with a bone filler, because that makes sense. Also, that makes sense because you have not only the stability of your blood clot, and you can keep the bioactive agent as the hyaluronic acid or the enamel matrix derivative in situ. That makes sense. But the Emdogain, the enamel matrix derivative with the hyaluronic acid, I don't see. For me, but maybe would be an interest, but I don't see the interest.
Some questions with regards to the differences between natural hyaluronic acid and cross-linked hyaluronic acid.
I think is the capacity to stay more in situ of the exactly the cross-linked hyaluronic acid.
Exactly, the cross-linked hyaluronic acid that you are using is staying between 4 to 6 weeks in situ.
Exactly.
A natural one would be resolved in days.
Exactly. More or less 6 weeks. Yeah.
Is there any side effect of using HA? And did you ever had the use hyaluronidase after treatment with HA in periodontal therapies?
No, not at all. Really, there is. I have started to use hyaluronic acid, I think more than 3 or 4 years ago. Yeah, I think 4 years ago, and I had never experienced any side effect, any experience. And also, the hyaluronic acid is a major component of our body. Is for some patients is better accepted than you have to inform your patient the origin of the bioactive agent. You have to inform the patient. Therefore, with the hyaluronic acid is much better accepted for some patients than for instance, the enamel matrix derivative.
Thank you. Here, a question that is more about your clinical protocol. So HA, you put over only CTG or sub that is in contact with the root.
Yeah, the hyaluronic acid, yeah, the is on the root surface, or in the infrabony lesion, and I applied when you harvest, because you prepare first the recipient site and you do everything that you have to do. Afterwards, you go, you harvest the connective tissue graft, but you have to suture the donor site. And at this moment, I apply the agent, the hyaluronic acid, over the connective tissue graft. And afterwards, I place my connective tissue graft, and once again, I apply everywhere the hyaluronic acid. And when I suture the flap, I do once again.
One question about using PRF with HA.
I do not have any experience with PRF and HA.
And maybe a last question. So what type of sutures are you using? Are they resorbable?
Yeah, sometimes are resorbable sutures. It depends also the patient, but most of the time I use monofilament. Sometimes
Good. So I think we've been around all the questions and all the nice comments that you've received, Doctor, for this great session.
Very much. Thank you very much. It's not easy after working day, but I think all of us, we are in the same conditions. Maybe it was for everyone the same as me. Therefore, thank you very much. And I have only one regret, that I cannot see the people. Really, only one regret. I hope that soon, very, very, very soon, we will come back to our normal life.
Absolutely. Thank you so much, everyone, for attending this session. We will share this material with you. Of course, if you want to have more information about this topic, feel free to contact us. Or we can also recommend a very good training center, the 26K in Paris, that your doctor are heading with your colleagues. for theoretical and practical education on periodontal surgery. We will have and we will continue to do some webinars about this topic in 1 month, actually, or a bit less, the 5th of May, with Dr. Friedman. Until then, well, I wish you all a good evening or a good day. Stay safe and stay healthy. And Doctor, I leave you the word for the end.
Thank you very much. Thank you very much. And also, what I would like to tell you that I hope see you soon, all very, very, very soon, and stay healthy. Bye.
Thank you. Bye-bye.
Bye.